All right, thank you everyone for joining us for today's HTRC Education Series session. My name is Haley Bell. I'm the Program Manager for the Heartland Telehealth Resource Center, and I have the pleasure of hosting our session today. Just a few quick notes for you before we begin. The session is being recorded, so we will share it with you afterwards once we've processed and edited it. Please use the chat to ask any questions you have throughout the session, and we will have some time here at the end to run through those. If you would like a completion certificate, please contact us at htrc@kumc.edu, and please include your full name as you would like it to appear on the certificate. And then, as I mentioned, we do have a lot of information to go through today, so our questions in the chat will be monitored, and then we will save those for the end. But all questions, we'll document them and share them in our follow-up email. So even if we don't get a chance to answer them live, they will be answered following it. So to go ahead and get started, I would like to introduce our speaker, Dr. Tiffany Griffiths. Dr. Tiffany Griffiths is an advanced practice registered nurse and the CEO at Eastern Oklahoma Medical Center. She's received her family nurse practitioner and Doctor of Nursing Practice degree from the University of Central Arkansas. She led the development and implementation of school-based telemedicine within multiple schools in LaFleur and Latimer counties. She's also worked with state legislators and agencies to update telemedicine laws and rules to streamline use and reimbursement of school-based telemedicine services. This program started with 2 schools in 2018 and has since expanded to 14 schools across 2 counties, as well as being the example for other programs across the state of Oklahoma. So thank you so much to Dr. Griffiths for being with us here today. I will go ahead and pass it over to you.
Hello, everyone. Welcome to this presentation for transforming school-based telemedicine programs. We're happy to present to you today. We come all the way from Hodo, Oklahoma, so I'm sure there's lots of different states on here to look through this, and I hope you guys are excited about school medicine like we were. So with that, we will go ahead and start. So like Haley said, our program started back in 2018. This was really kind of the development about it was really focused on our community. We are one of the largest counties in the state as far as square miles. But we're also one of the lower on the socioeconomic area with it. So we know that while we're a big county, there's not a lot of health care in our county. We're actually the only hospital in the county that we serve. So there are some in the surrounding areas, but as far as directly affected, at this time in 2018, there really wasn't a lot of healthcare options for patients and stuff. And so while going through my DNP program, this was actually one of the papers and research articles that we had to start reading and researching with it. And so while we were going through that, it was kind of the idea of why can't we do this here? So at that time, Oklahoma didn't have any programs like this. So is kind of difficult and to try to figure out how we needed to get it implemented and all of that stuff. And so we're kind of walk through that today on how we got it going and kind of how we come up with our processes and our programs and all of that stuff in order to make it effective. So let's see here. Okay, so talk a little bit about EOMC, so Eastern Oklahoma Medical Centers, and our program vision, just the development of the program, our impact, and then also our community partnerships. So I think all of these areas are extremely important in having a successful program. We've really worked hard. We have a lot of community engagement when it comes to our programs, and I think that's one of the reasons why it's done so well in our area. So here we are, LaFleur County. You can see in that little blue part with a little star there. We're population just under 50,000 is what we serve for our county and over 1,600 square miles. We are a county-owned facility. We have a hospital and 3 rural health clinics that are attached. Founded back in the 1950s. We are a nonprofit organization, HIPSA designated area, and we actually have 17 school districts within our service area or within our county. So one of our visions with this was to be in when we first started this program, we wanted to be in every school. So that was kind of our goal of getting there. A few fun facts about Poto. So we have the world's highest hill here. We are 1 foot short of being a mountain. So you can see that there. And then we have the longest running balloon fest in Oklahoma. So a couple of nice things to know about Poto. It's a nice, beautiful area. And you can kind of see we are out in the rural areas with it. So, when digging into these programs, as I was looking through different states and how they had their setup, kind of the purpose of these programs, these were the three things that come into mind as far as how did we want to impact our community with this program. So, being county owned, of course, our focus is serving the LaFleur County citizens, is where we wish to be. And like I said, at that point in time, we had less providers in the area. And in order to kind of, the hospital is conveniently located on top of a hill. And so kind of the thought process of that is how do we take our care to them? How do we get to people who cannot afford to drive to the doctor? How do we get to them, especially in our really rural areas? We have some that are, 30 minutes away, and they certainly can't afford gas money to get to the doctor or medicines or things like that. So how do we bring healthcare to them? We looked at improving and promoting the availability of healthcare in our rural and underserved areas. So that's pretty much our whole county. Reduce barriers to care that exist in rural communities. We know access to care is a big one there. Health literacy is another one. So just kind of encompassing all of that stuff in there. And improving access to care and convenience for patients. So we wanted to make it easy for them to be able to see the doctor or see your provider and help those preventative care visits and get them taken care of. So we knew that going into this that they have to be physically healthy in order to learn. And so we wanted to make sure that we were able to provide that part of that availability for them. So with our development of the program, like I said, this kind of started while I was in school and figuring out all those other programs, and then we just try to figure out how we wanted to get it implemented. So we're going to talk a little bit about challenges, our process, and then our implementation with this. But I think all of this kind of goes back to I had no idea what I was doing, and so just trying to enlist people who had that expertise, had that specialty. So my first call was to the Telehealth Alliance of Oklahoma. So they're our professional agency here in Oklahoma that deals with telemedicine. And so trying to get a hold of them and kind of walk our way through things. I certainly didn't have any idea on that at that time that we needed to get laws changed, that nobody in the state was doing this. So we really honestly didn't even have anyone to ask for help when we were trying to implement our process with it. So once we got started, I think we started in August of 18. So remind you that this is pre-COVID. In our area, telemedicine was not utilized at all. We have a radiology service here at the hospital that has always been teleradiology. So, but the patients don't see that portion of it, so they don't realize that side of it. So, this was really before you could talk to a doc on your phone or anything along those lines. So it was a lot of things that they weren't accustomed to. So probably the metro areas was a little bit more familiar with some of this stuff. But digging into it, we started our program in August of 18. We wanted to pick just a small school to implement into because we didn't want to get too big too quickly, and make sure iron out all those processes to make sure that it flowed well whenever we decided to move into our other schools. So like I said, one of our biggest goals was to be in every school within 5 years. But we knew we needed to start small, work the kinks out, and then push it out to the other organizations within the county. So once we got started, and then we started looking at Medicaid rules and things along that nature, and reaching out to them and asking them questions, what we quickly realized was that we could not bill for these services without the parent being in the room due to the way the rules were written in Oklahoma Medicaid. And so in questioning them about, well, how do we, because the whole point is one of the other points of this program was to be able to see these kids get the health care that they need. So their parents aren't having to miss work. They're not getting drug out of school, and missing half a day and all of that stuff. So how do we make this work? I don't know about if y'all are in rural areas or not, but a lot of the jobs in our area are factory works, or factory workers, and they take a very hard stance on people missing work. Literally a three strikes and you're out. So, kind of what I relate this to for everybody is I don't know about y'all's kids, but my kids never get sick at the same time. And so one might have strep throat today, and then 2 weeks later, the other one catches it because they like to share. And so our kids don't get sick at the same time, and the parents are having to take off all of this, which a lot of times leads to them losing their job. Then they're losing their income. And so then they don't have the ability to take the patient to the doctor because they can't afford to, or things like that. So how do we keep that parent at work? How do we keep that kid in school? They learn best if they, are continuously in the classroom. And we know that going to the doctor, a lot of times you miss half a day of school. So if my child has a doctor's appointment at 1:30, they always want out before lunch so we can go have lunch at McDonald's or whatever. And you go to your appointment and you wait there, and usually, might as well be there about an hour or so by the time you get checked in, see the doctor, and then leave. And we're not going back to school after that. Or even if the appointment's at 10 o'clock, you're usually missing most of the morning. These appointments typically take 10 to 15 minutes. They're located there at school, so you're not missing that much time out of school either. So the more these kids are pulled out of school, they're missing that educational content while they're there. It's kind of disrupting the class when they leave, and then they come back and gets the teacher off their train of thought. And so there really is a lot of disruption when a child is being removed from the classroom in order to go to the doctor with it. So lots of different things that we were looking at through here in order to kind of make this process work. So, but like I said, we found that because of the laws, we weren't able to do it the way that we really needed to design the program to have the most effectiveness. And so that was, like I said, that was one of the big reasons we reached out to the Telehealth Alliance of Oklahoma, was to kind of help navigate through that process. Because I, for one, had never dealt honestly with any legislators to try to get laws passed or words changed or anything along that nature. And so it was a brand new world for me when it came to those types of things. And to be honest, it was pretty nerve-wracking with it too. So but that's where we started with it, is trying to make sure that we were able to be paid for our services when we could. I will say that we've kind of taken the stance that, we want the kid to be seen, we want the child to have the care that they need, and we may go into that a little bit later, but that was kind of our vision of the program in order to make the most out of what was going on with it. So, I would say probably one of the biggest challenges that we faced with it was, of course, the legislative challenge. So this is one that we honestly are very proud of, just because everyone knows that when you go to get a bill passed or the law changed or anything along those lines, it usually takes some time. It usually takes some failures. Just it takes a long time usually. And a lot of times it doesn't get passed the first time it's in those committees, or it gets tabled and it gets pushed to the next year, and then sometimes tabled again. And so it may be 4 or 5 years before the program is actually able to function. And going into it, that's honestly what we assumed would be our process, is that we were looking at 4 or 5 years down the road to get what we needed completed prior to really being able to run the program like we wanted to. But to much of our surprise, because of the Telehealth Alliance of Oklahoma, and because of our legislators at the time really buying into the program, they were a huge success. And honestly, that is who should take the credit for getting this stuff passed for us. So We, like I said, we enlisted the professional organizations within the state to get their guidance on how to go through this program and move through the program. Conversations with Medicaid to see how we needed to get it done. So they shut us down pretty quick about we can't help you anymore. You need to talk to somebody else when it comes to that. They didn't want to answer too many of our questions, but at least it kind of got us pointed in the right directions. We did get a hold of our local legislators, our House representatives, and our senators, and then they enlisted some help from some of their colleagues to help push this program through. So we were excited about that. We actually brought them down to the hospital and demonstrated the program and talked to them about the purpose of the program. And they were great about jumping on board and really following up and making sure that we were able to provide this service. So we were really fortunate that we had some open-minded legislators at that time. Um, the Telehealth Alliance of Oklahoma also helped us with language development, along with our one of our House of Representatives. He was actually a psychologist, and we knew looking forward, we knew that this law was just not for now. We wanted it to make sure that the way it was written, that it helped moving well into the future. So again, this was pre-COVID. This was honestly before a lot of telemedicine was going on in our community, but we knew what was coming for the future with it. So the other thing that we realized is while we did not want to get or wasn't our purpose to get into the mental health or behavioral health areas of school-based telemedicine, but we wanted to make sure that it was written in a way that that was a possibility in the future if it was needed. And so, with the help of one of our representatives who was a psychologist, we developed that language for that. There's an attorney on the Telehealth Alliance of Oklahoma, so she helped us develop that language, and honestly was a big part of kind of the back and forth between how the legislators wanted the wording, and then, well, that doesn't quite work on our side, and so really all of that navigating that part of it, they helped a lot with it. So. And then once we got it prepared how we thought it needed to read, of course, we sent it to them to get it approved. So this is the part that honestly is kind of uncanny and just does not happen very often. You can kind of see with current legislature right now that things just don't get passed very often, much less a general consent, uniform that everybody agrees with what's going on with it. So back in, or I guess it was February 4th of 19 is when our State Bill 575 was introduced. They sent it to the Education Committee first. So it was reviewed on 2/20 of 19, and then it went to the House for a vote. The House passed it 46 yes with 0 no's. So that was really exciting for us. That doesn't happen very often. It then went back to committee. And they sent it once they got it approved. It went back through. It then went to the House or to the Senate on 5-2, and it passed the Senate 44 yeses and 0 nays. So there's not very often that those bills go through where there's not a lot of negative connotations attached to those. So we were really excited about that. And then on 5/9 of 19, the governor signed it. So our bill went through flawlessly. Again, all the credit to the legislators on their work and talking to the other county legislators individually to have them understand the idea and the vision behind the program. And then also in the language, it was written that this was an emergency bill. So what that means is while the governor signed it on 5/9 to be active, the effective date started August of that year. And so with having that on there, otherwise it would have had to wait until the whole next year before it was active. And so that is just a really impressive process of how that went through. Really was no hiccups as far as getting it fixed to that in order to get these kids the care that they need. One thing that we find a lot of times, and we've just had school nurses tell us over and over and over, is they would not, I had this child in my office and they would not have received care if it hadn't have been for your telemedicine program. We have a lot of grandparents taking care of grandkids, and they just honestly can't afford to even drive 20 minutes to take the kid to the doctor, then go to the pharmacy, and then come home. Really, their transportation, at least for the child to get to school, is the school bus. And short of that, they don't have any other transportation. A lot of times, our school nurses would go pick their medication up and bring it back and send it home with the child, or they would. Um, you know, sometimes they would even keep the medicine at school so they could make sure that the child received the medicine like they needed to. So lots of different ways to do that. But at the end of the day, we had several children that would not have gotten the care needed if this hadn't have been in place with it. Another challenge that we experienced was trust. So I know I keep referring back to, this was kind of pre-COVID with it, but one thing that we looked at is, the school is considered a safe location to send your child to. You don't think about like anything's bad's going to happen to them there or anything along those lines. And so we kind of had to dip into that safe space in order to get this program going and make sure that we did it efficiently. We built their trust. We got the trust of the staff. We got the trust of the parents in order to make this program succeed. And us realizing the entire time that we are caring for these parents' most prized possession. So this is their kids we're taking care of. So we took that very seriously. We know it's at a vulnerable time. So when when your kid is sick, you feel helpless a lot of times. And so really working on that communication with the parents to get their trust, to make sure that their kid is being taken care of and being seen, especially by a provider that they don't necessarily know. So when we developed this program, it was probably a good 2-week wait before you could get into the doctor. So if I have strep throat today, it's going to be 2 weeks before I can be seen, unless I go to the emergency department, but that costs too much money and I can't afford to do that. So I'm just not going to go get seen. And so things have changed a little bit now, but at that time, it was a good 2 weeks, and that was with all providers in the area. So we wanted to make sure that we kind of stepped in and was able to get them taken care of the way that they needed to. Um, Social media. So this was one that we took some PR hits when we went out there and first. We had some comments on there about I would never put my kid in front of a TV to be seen by somebody I don't know. I think it's a little bit different these days because you get on your phone and you call a doctor that you may be in 3 states away, and they send your medicine in and all of that stuff. So it's a little bit different these days. But at that time, it was a big deal for them to put their child, especially if they're not there, put their child on a TV or on the internet and have that evaluation done. So we had to work on a lot of trust during that time with the parents on that part of it. Um, School buy-in. So this one's another big one that we had to work through. We had to make sure that they understood our mission, our vision of where we wanted to go with this program, how we wanted to get it done, and how we wanted to get it implemented. So first off, of course, is administration. You have to have their buy-in in order to even get into the school, and of course, they have to get the buy-in from the school board with that too. So lots of people that we had to talk to, and questions we had to answer prior to even, attempting to get into the school for that part of it. The school nurse. So they are integral in the success of the program. If the school nurse does not want to do this, then your program is going to be completely unsuccessful. So when we first started, we had a couple of schools that had some nurses that just they didn't see the purpose of the program and they were not going to use it, and those programs did not do well. They've since changed staff in those departments, whether they've retired or have moved on or something like that, but now we have different nurses, and a lot of them have really taken this and flown with it. So but we have found that the school nurses who are bought into the program, they have a lot better program than or a lot more success than the schools that do not. So the teachers are one. When they call the mom or the dad or grandma or grandpa saying, "Hey, Susie's sick," they have to know what is available in order to offer that to the parent. So, if they don't say anything about the telemedicine program, then parent or grandparent's not going to know. But when they're calling saying Susie's sick, would you like them to be seen by our telemedicine program? Sometimes that opens a door for them to say, yeah, I would. And it's one of those things that kind of what we wanted to do is be able to identify, um, infectious versus non-infectious. If they're not infectious, then they can potentially stay in the classroom. If they're infectious, we need to get them out before they share everything. We had to get the buy-in from the parents. So, kind of back to that trust issue, we had to make sure that they were okay with us doing this with their child. And then also the buy-in of the community. So several different areas that we really needed to concentrate on in order to make sure that our program was successful on that portion of it. Um, so our process with our telemedicine program, so kind of followed the KISS method on this one. We wanted to make it as simple as possible with our school nurses. So we had lots of grand ideas when we first started that the school nurses would get into the EHR and do the documentation, put their vital signs in and do their kind of history and things like that. But when we really got into looking at the program and then honestly just visiting the school nurse, they are so crazy busy every day. So just the 30 minutes sometimes that we just go do a site visit check with the nurse to check in to see how things are going, in that 30 minutes she'll have 30 kids in her office, and so they are so busy. And so that kind of gave us the realization that this is kind of how we thought this was going to work. There is no way that this would work. So we wanted to make it easy for the school nurse and just as simple as possible so they can continue their job. If we make it hard on them, then they are not going to promote the program. The program's not going to be successful. So we need to make it very, very simple. So currently what we do is we are required to get consent every year for the child to participate in the program. So we got to make sure we have a consent on them first. Typically the child presents to the school nurse. They do a little triage to see whether, Johnny needs to go home or whether he would be a telemed candidate or whether he just needs to go back to take a Tums and go back to class. So they kind of triage for us. And then once they decide that they want, or they talk to mom or dad, and we've got a consent, and they decide that they want to do a visit, then a lot of times they'll just text or call the office and say, "Hey, I've got one here for you. Can you jump on?" Or, "Can you meet at 10:15?" Or some different things like that. So, but they'll communicate with the provider to see if they have availability. We usually try to prioritize those because we want to get those kids in and out of the nurse's office so they can either go back to school or go home. And so they'll get their exam there. So we do have a full telemed capability. So we've got the otoscope and the stethoscope there at the school. And of course, it's got a camera, so you can see that. This is the part that the kids really like because they get to see in their ear and they look up their nose and they look in their throat and all of that stuff. And so they really like to do that portion of it. We've got the stethoscope where we can listen to their heart and listen to their lungs, and the nurse will take some vital signs and weigh them for us and get a brief health history from them that we can then document in our chart and everything. So we can make sure we do a complete exam on that patient. So much better than picking up your phone and doing that type of visit. So once that's done, if the patient has some type of bacterial infection or they need a prescription or something like that, we send the prescription to the pharmacy of choice for the patient or the parent, and then they can go pick it up whenever they want and kind of go from there. So one thing in talking with this is, the whole focus of the program was initially for the students, but the more we talked through it, and this was with administrators and things like that, kind of their question popped up as, well, can our educators use it? And so, we got to thinking about it. I was like, well, teachers get sick too, so why not? And so we opened it up to the entire school system, the educators and the students in the systems to be able to use the program. So we've kind of found a 50-50 mix, but we'll kind of talk about that a little bit more here in just a minute. But again, just trying to keep it as simple as possible. We know those nurses are super, super busy every day. It's constant turnaround in their offices. If you haven't ever visited a school nurse, I encourage you to do so. But they got 90 million things going on. So try to keep it as simple as possible in order to not disrupt their workflow, but also able to get that patient taken care of how they need to, and go from there. So we do bill it as a rural health clinic visit. So with COVID, those restrictions have kind of loosened up a little bit. So we're able to bill it that way. Prior to COVID, it did not qualify because we were not let's see, we were not the site in order to bill for that, and so we kind of just had to do it a different way for that one. But that's kind of how we've managed it so far. We have kind of talked a little bit about it earlier. We've taken the stance of we want these kids to be able to receive health care. And so if they have some financial needs, we have means in place to kind of assist with that or determine that part of it. But if a kid presents, we see the kid and we worry about payment later. So being county owned, that's our purpose. We understand that other organizations don't necessarily function that way. But that is one of the things that we wanted to make sure that it was embedded in our program, is that we're here for the kids and we want to make sure that they're healthy physically so they can so they can continue to learn optimal. Implementation wise, so again, it goes back to education. So we had to talk to the school board, how to talk to the parents, school nurse, educators, and the community. So social media platform, as far as letting everyone know what was going on, and how to get that going. And just a lot of times we would show up at usually have a little day prior to school starting that we call it open house here. We'd go get a table or a booth at their open house so we could give out information on that. Had some consent forms available if they wanted to take them with them, and that way they could get them done. We do let them now fax them in. So usually the nurse kind of keeps them there in her office. And then if the parent needs to come out and fill them out and then do it that way, they can, or they can fill them out at the beginning of the year and then they're taken care of. So, as far as that's concerned, is when a child present, even though we have written consent, we still call the parent every time. So, we don't want to just see the child or bill the parent for a visit just because they're coming in. If parents don't tell us yes, then we don't do the visit. So, the nurse will get on the phone and call Johnny's mom and say, "Hey, he's sick. Do you want him to see telemed?" And they say yes. Then we do the visit. If they told us no, then we wouldn't do the visit despite him having a consent on file. So that's just kind of how we've ran our program on that part of it. But we want to make sure that the parents are involved. Once the visit is done, if the parent is not there in the room, we call them to give them the discharge instructions, so say. But just to kind of go over medications, things to look for when you need to take them to the emergency room and all of that stuff too. So, we also, when it goes back to talking about some challenges and PR stuff, some people viewed this as trying to steal patients from other doctors in the community. And so we had to do kind of some de-escalation as far as that was concerned. If we're not trying to steal anyone's patients, we're just trying to fill gaps. So when they can't get into the doctor, we're there and available for them to make sure that they're seen in a timely fashion. So just a lot of education went out within the schools, within the community, in order for them to understand the program with it too. So this one we talked about just a few minutes ago as far as who we serve and what we offer with this program. So we found a 50-50 mix between the students and the faculty. So majority of the 50% of the students are pretty much the elementary age. Don't really find a lot of usage in middle school or high school with this service. And I could just kind of attribute it to if you have a 5-year-old that has a sore throat, you're probably more likely to take them to the doctor to get them checked out than you are your 17-year-old. And so, we see a lot more of that volume with it. We were really surprised when we started this program of how much of the educator population that we started seeing. But after talking to them, we we've seen that they are able to, it's so convenient for them just to run down to the nurse's office and be seen versus having to leave work, go to the doctor, pick up their medicine, and then get back to work. And so what they would do is sometimes they would text the school nurse, "Hey, can I do a visit at 7:30 in the morning?" So they would try to do it before they started school. They would do it on their planning period, or immediately after school, and then go pick their medicine up either on one of those other time frames. So if they did their visit at 7:30, they'd go pick their medicine up at lunchtime or on their planning period or something like that. And so they weren't missing as much school either. And so that made it good. There's several different things that occurred because of that. But anyways, as far as what we see, that was kind of the biggest trend that we found with it. What we do on services offered. So we do on-site testing at our schools. So we bring our school nurses in once a year, do competencies on them for strep testing and influenza testing. And then we actually purchase those kits for them and send them back to the school. Um, Again, just to make it as easy as possible, we also don't want any financial strain on the schools. And so we incur those expenses, especially with us billing for the service. We just feel like that's the right thing to do on that. But the nurses come in, they get trained on doing those testings. And so if I'm the provider that's doing the telemedicine visit, I can say, okay, go ahead and strep test them, go ahead and flu test them. It takes about 10-15 minutes to get those results back. But we also know if that child is infectious or not. And if they come up positive, then we need to get them out of the classroom. With strep, you can start them on medication. They be on it for 24 hours. Then you can turn right back to class. Influenza, they need to be out a little bit longer. So we can do all of those different things and try to get them out of the classroom before they spread it to the rest of the classroom if possible. So I kind of always say that those, especially the elementary age, they like to lift, sniff, and touch everything. And so we just want to make sure that they're not doing that with each other and get them out of the classroom so they're not spreading those germs to everyone else. And then the entire classroom is out. And maybe even the teacher too. Everybody's out because they're sick. We offer the prescription piece of it, so we can send it to whichever pharmacy that they would like. And then also the health education to hit that health literacy piece of it. So going back to the parent, if they have strep throat, make sure you're checking their temperature and, giving Tylenol, rotate Tylenol and ibuprofen and change the toothbrush and just different things like that. Don't drink after anybody, don't let them drink after anyone. So kind of gives us an opportunity to provide some health education when it comes to providing those services with it too. So we know if they don't have the education, then think they're going to do exactly the same thing and most likely get reinfected and have to do that again. So impact of the program. So these are some areas that we found that we personally seen with our program. Access to care. So again, right now we're in 15 of our 17 schools. So over the last several years, we've been able to find some different sources of funding to help us get there with it. So we are excited to serve that many schools with it. We've also acquired our local college. They've got 2 campuses, one here in town and one about 30 minutes away from us. But we have started providing services for them also. So it's a smaller community college that didn't necessarily have a clinic or an infirmary like some of the larger colleges do. And so they have a lot of international students that show up. They have a lot of students from out of state that don't necessarily have transportation. So this was a good avenue and a good fit for them to be able to provide those services to their students. So the access to care was one of them. Again, like I said, we have some people that can't afford gas money to drive to the doctor. So we're just in a really socioeconomic deprived area with it. So that helped us with it. Reducing absenteeism. So our schools in Oklahoma do get reimbursed based on attendance. And so if we can keep students in the classroom, that definitely helps with their financials. So schools were very excited about that. I know when we talked to Poto, which is one of the schools that we started with, they had, I mean, it was a crazy amount of days. Like they averaged 30 days missed per semester per kid. So it was just a ton of days that these kids were missing, and tracking mechanisms for it too. So those were things that, we wanted to make sure that we were meeting the school's goals of the program. So every school's a little bit different. So those conversations were had individually to make sure that they knew what our goals were, and then how we could help them meet some of their goals that they were looking to accomplish with the program too. So very much a joint effort with this. School financial. So talked about the absenteeism piece. The piece that we didn't really think about until after we added the teachers in was the cost of substitutes and the cost of the teachers missing classroom time. Not only does it set back the classroom as far as educational continuity, but the teacher, each school is a little bit different. So some schools, the school pays for the substitute the entire time. Some schools do like a shared cost where you can miss so many days, but then after that, the teacher actually has to pay for their substitute. So we found it both ways in different schools, just depending on which one you were talking to. But, when you think about it, when the teacher misses, the school is having to pay the teacher for whether it's vacation time or sick time or whatever, but then they're also having to pay the substitute. So that's kind of a double expense when a teacher is out. And so if we can keep them in the classroom as much as possible, they're not missing their vacation days, or they get to spend them how they want to instead of being sick. But also the school is not having to double pay in order to cover that classroom. So they liked that idea, kind of save them some money there, save and get them more money for reduced absenteeism. And so they jumped on board when we started talking about those pieces of it. So, and then educational continuity. So I don't know if when you guys were in school or not, but when I was in school, if we had a substitute, that pretty much meant a free day of class. And so we really enjoyed our substitute being there and played all kinds of tricks on them, and probably weren't the best students in the class. But anyways, but you don't really learn a whole bunch when your substitute's there. And so if we can keep those teachers in the classroom, that educational continuity improves, and they're able to keep their classroom online for their plan development and all of that different things. So it just really helps all around in order to get all of that stuff done and move along through there. So, again, it's some of those things that these wasn't really the initial impact of the program, but it was things that happened kind of along the way, and lessons learned, and all of that stuff that went with it too, that we were happy. We didn't know that it should have been a goal of the program, but after looking back, we're like, that was really good. And so I know that first year with Poto, and it's hard for us to track the absentee piece of it because we're not privy to all of their absences that they have at the school. And so we asked them to kind of keep an eye on that and track that for us and stuff. But I know with Poto, and they're a 4A school, and they're a pretty large school here in the county. But they told us that they had a 30% reduction in teacher absenteeism that first year that we rolled that program out. And the student absenteeism also reduced with that program too. So we weren't able, of course, to attribute everything to that telemedicine program, but we were able to attribute quite a bit of it to it. So the other thing that it helped with was a lot of times the schools don't receive notes. And so if you don't turn a note in, then it counts as an unexcused absence. So we were able to kind of fill that gap for it too, of being able to say that this child is sick, they need to go home, or things along that line. So they were better able to track on why some of those students missed class, and even the teachers too. So, which of course impacts school financials and things like that. So, and we know the more the kids are in the classroom, the better they perform on their end of year testing, and things along that nature. And so, all of that just kind of bundled up, honestly, without us realizing that those were important impacts of the program, until the end of the year when we got to really talking about it and looking at it and figuring out, where did we want to go with this, and how do we get there? Um, so really the last thing that I have for you guys is just the community partnership and funding. So I know these days everyone's looking for grants and looking for grants and looking for grants, but there are some alternatives that you can come up with without having you to personally apply for these grants. While there is a lot available, we kind of took a different route on that. We didn't have a grant writer for us or anything like that, but just trying to figure out how we can make this work. Um, when we were talking to our board for approval with that, it got out into the community. And so we actually got supported initiating our program through some local banks. And I don't know how large of communities you guys live in or not, but ours is fairly small. Like I said, the whole county is about under 50,000. Probably the Poto area is right around 10, probably maybe not even that big. But we have a lot of local banks, local communities, a lot of civic organizations that are always looking for charitable events, or ways to give money back into the community. And so we tapped into that one in order to help initiate our program with it. So one local bank donated enough to implement into five school systems. And so that was extremely helpful with it. And then we kind of did a little, well, hey, talk to this bank, and well, this one's giving this much, and would you like to join or beat them or anything like so. A little healthy competition amongst the banks was nice. We were able to get a few more units that way. So as far as the local civic organizations, we actually had our Lions Club, they co-opt with the local bank to buy a unit for their town, is how one school system got theirs. We had there's an insurance company that was looking for some community organizations that they could give some money to. So they actually co-opted with one of our electric co-ops, and theirs went into a really rural school because they wanted their money in a rural school. And so that unit went into that one. And then the rest of them were supplied by banks. And so just a nice way to kind of figure out how to get it done without necessarily just a grant coming to you. Grant partnerships was the other one that really helped us out. This funded about half of our units. So once college, it's on the other side of the state, but they heard about our program. They want it in their side of the state. And so they actually wrote a grant. But the first year of the grant was to buy us more units to serve a higher population. And then the second year of the grant is they get units to start the program on their side of the state. And so while we're not responsible for that whole grant, we are a recipient of a lot of that money. And so we were very appreciative that they, engaged us in order to help us meet our goal. But also we will help them start a program on that side of the state. And so that's kind of getting some money without necessarily doing the grant ourselves. And so just a little bit of out of the box thinking, because everybody always seems to just either rely on grants or how am I going to pay for this or anything along those lines. And there's so many different foundations or even just local community organizations that are willing and usually always looking for some type of project to give money to stay in their community. And so just kind of tapping into those resources to make sure that they're available and you know what's open, and all of that stuff. And so this is, like I said, this is back in 18. So the program has kind of taken a dip in the amount of visits that we have done over the last several years. I know that I will say January of 2020. Of course, that was pre-COVID. So the first year of the program, 18 and 19, we had about 125 visits between two schools, which we thought was pretty good. pretty proud of that for just starting out. That next year we rocked along pretty good, especially in the fall. And then in January of 2020, we did over 100 visits that month. Little did we know it was COVID. So that was right before COVID came out. And like I said, January, it was a tremendous month, especially being a short month in the school system, in the school schedule. So, because you don't start back to school until usually that second week of January. But we had a ton of visits. We didn't really know what we were seeing at the time, but, kind of treating for flu and symptom management and then moving on down the road with it. And then right about, I would say February, it came out that we had COVID in the United States. Our schools, we continued through school until spring break, and then after spring break, they never returned to school that year. So once that year got over, and then everybody was so careful with what they were doing, especially being that first year of COVID, that the schools were pretty much, if you have a headache, they sent you home, or if you have a cough, you go home because they didn't want to spread that to the other children in the area and to keep students in school and stuff. And so we're kind of working out of that now. Also during this time frame, we've had some new providers in the area, so it's a little bit easier to get into the clinics that you need. Telemedicine services are much more readily available than they was back in 2018. So still facing some challenges today, but just trying to figure out some ways that we can work through that. But it's always there. It's always ready. It's just trying to figure out how you can fill that void and how you can fill that gap in order to meet those kids' needs and in order to meet your community needs, and to be able to just provide those services that everybody is looking for and help your community out. So I think that's all I have for today, Haley. If you have any questions.
Yes, thank you so much, Dr. Griffiths. I loved learning a little bit more about the program and challenges and outcomes you've seen. So thank you so much for joining us today. And we did have quite a few questions come in through the chat, so we will go through a few of them, whatever time allows for, and then any other ones we will answer in that follow-up email. To get started, there's a question about what vendors or technology you're using for the audio video portion of the visits, and any digital devices that you're using, if any.
So our current platform we use is AMD. I don't know exactly what it stands for, but that's the platform that we use. Of course, on the provider side, it's as simple as a webcam and audio, and a headphone set. That's really all we need as far as being a provider and providing the services. But AMD, it houses the software and it also comes with the ancillary equipment. So the otoscope, the stethoscope, those types of things in order to do the visit on the student side.
Perfect. Thank you so much. It looks like there are also questions with the providers. So looking to see if there were EOMC providers that were exclusive to the program or just where in general the providers are located.
So we used a couple of different avenues. I was actually the provider that did the majority of the visits, but since I have come back across the street to the hospital, we've got some different providers that's doing it now, but we do have two or three. We honestly use it to fill stop gaps or fill holes in our schedules. So usually now they contact the clinic manager and she looks at the schedule and to see who can take a visit, and then they plug them in with that provider. And so we've kind of adjusted over the years in order to accommodate, but everybody kind of has a flow. It works really well. The nurses are fantastic and usually have all the questions answered before I could ever get on the visit. And so really we just had, and AMD also offered the ability to take pictures, and so they could actually take pictures of the ears and the throat, and I could just flip through the pictures as I'm talking to the patient about their symptoms or how long it's been like that, or, mom, what's the allergies and stuff like that, as I'm flipping through the pictures of the ears and the nose and the throat and all of that stuff too. So really the only thing that I had to do during the visit was listen to the heart and the lungs. And so most of these visits are simple office ENT visits. Like I said, it's mainly elementary kids. So we've seen a lot of ENT complaints, sore throats, runny noses, cough, congestion, ear pain, fever, those types of things. Of course, trauma patients, we did not, like if they fell and off the playground and their arm is dangling, we do not want to see them on telemed. They need to go to the emergency room. Or if they're having some belly pain, I cannot evaluate that through telemed. Somebody's got to lay hands on those belly pain patients. And so they need to go seek services in a clinic somewhere. We did have on occasion where, if we were seeing the patient and we felt they needed to be seen, I'm like, can you bring them to the office? Like, I can't get away. I need to lay hands on them or take them to the emergency room or something. But they need an in-office visit. And so parents were not upset about that. They understood. And so just that communication worked really well. But dermatology, you can look at the skin for a rash or different things like that. So there's lots of different things that you can do for different complaints, but we were able to handle most of those.
Great, thank you. Kind of following up with that, another question was, how would you handle a situation where a child presents symptoms that can be contagious, but there is no caregiver at home?
I think I'm a little confused. I don't know if they're asking about consent or I mean, we have had situations, like I said, if the school nurse was concerned, because I'll be honest, those school nurses know those kids way better than I know those kids. They see them every day. They know the ones who have a good support system at home. They know the ones who have no support system at home. And so the ones that do, they're able to communicate those things effectively. The ones that do not, we made arrangements or like I said, sometimes they would go pick those medicines up for the students and keep the medicine at school. And that way they knew, and the kid knew to come to the nurse's office before they left school and before they got, or, first thing when they got to school, they took their medicine and they went to class. So each school site was a little bit different, but we always tried to make sure, and it's not any different, I would say, than a clinic visit. You do your best to make sure you work within the parameters that you're given. So, like I said, those school nurses know those kids. They know who has those support systems or not. And so we would just work together to make sure that they got what they needed.
Great, thank you so much. Looks like another question was, does the school need to be a billing organization, so a state Medicaid eligible clinic for telehealth in schools for billing state-based insurance through the provider distance site, or is this teleschool visit a self-pay model?
So ours, we bill through our rural health clinic with it being our providers. So we don't employ the school nurse. The school nurse is a school employee. And so this at our schools, and this may be different in different states, and it may be different in different counties, even here in Oklahoma. So everybody runs their program a little bit differently. And so ours, we did not require ours to do that. I know that I think a lot of them are because now they can bill for those services in Oklahoma. The school can bill for those services in Oklahoma, but that's not the way our program is set up. It's through our organization is how we bill.
All right. And then kind of in that same vein, with the teleschool visits, do you separate FERPA data privacy from the hospital records and keep the patient's HIPAA records separate from the school records, or is there an overlap with that?
Yeah, so the school doesn't keep any records except the consent. And the information, and even on the patient registration part of it, there's no health information on there. I mean, short of date of birth and name and that type of stuff, the school has that information already. So the documentation goes into our organization's electronic health record. And like I said, the school and the school has a typical. I mean, they usually have you fill out some kind of little form that says if your child is allergic to, or do they take any medicines or anything like that. So short of them having what they would have already, they don't keep anything extra.
All right. I think we have time for one more quick one. Um, like there was a question about if there were plans to include the parent in a synchronous video visit with the child and provider, or any other future goals to expand the program.
Yeah, I mean, we've talked about like a Zoom capability and things like that. So, or something along those lines. So we haven't really had any parents request to do that. So they're either there, and I will say that we still did have quite a few that of the kids that had to go home. But I will say of the ones that had to go home, it was based more on the school's policy for fever versus our recommendation as a provider. So a lot of the schools, especially prior to COVID, they had, if they have a temperature of 99.5, they have to go home. Us as a providers, like that's not a fever. So, but you want to respect the school's rules also. And so working through those things, but um we just tried to do that with it, but we really didn't have, some parents, they would come up on the first visit and then they were comfortable, so they didn't request to do a video consult in with it or anything like that. And so really it was just trying to meet the needs of what the parent wanted, what the patient needed, and then how the school nurse wanted to function with it too. So really a big collaboration between all three entities, the parent, the hospital, and the school, in order to make the program successful and get the student taken care of.
Great. Well, thank you so much, Dr. Griffiths, for all of the great information today. I know we've come up on time, so before we let you go for the day, I do just want to let everyone know that we will have some upcoming sessions in July and August. Once those details have been finalized, you all will receive the calendar holds with additional information. We will email the recording and follow-up materials, including answers to your other questions, as soon as they've been processed. And again, if you would like a certificate of attendance, please just email us at htrc@kumc.edu. Thank you so much for joining us today, and we look forward to seeing you all next time.